Hi guys. Um, the end is approaching very quickly. So it's Wednesday today. I'm leaving on Saturday night. Um, Today, I talked about yesterday. I didn't do a vlog yesterday. So yesterday I went to the Hope Centre, um, and it was really cool. I saw a lot of the patients that have been in the hospital, and so most of the patients that were here when I arrived and that I've gotten to know quite well are now at the Hope Centre. So I went out and saw some patients I haven't seen for a week or two, and hung out with them and did some colouring and stuff like that. And yeah, it was really, really fun. So that was a nice little send off to say bye to some of the patients that I've gotten to know quite well. So it was really good. And yeah, so that's yesterday morning, and then yesterday afternoon we just worked on a couple little projects that we've had going that I want to get finished before we leave. We talked about Guinea and staffing for Guinea and coming back, and I don't know. I'm thinking I might try and come back in October, but obviously that's work dependent and whatnot, so we'll see. But yeah, today, what do we do today? Today, Dr. Brian, one of the anaesthetists, talked about regional anesthesia, and it was interesting. There's a lot more. They do a lot more like regional anesthesia than I thought. So basically, all the like plastics patients and a lot of the ortho patients and stuff like that, as well as like a general anesthetic, they'll do a local nerve block. So for all the like arm surgeries and stuff like that, they'll do like a brachial plexus, like just inject lidocaine directly around the brachial plexus under ultrasound, and same for legs and stuff like that. They just do like a local nerve block, and it's basically improves the patient outcomes in a lot of ways. One is that it decreases the kind of immediate response that your body would have. Even under general anesthetic, your body has a response to like a stress response to being cut open and operated on. So completely blocking off the like sensory signals from that area will stop that stress response. So better kind of immune outcomes and stuff like that. Less long-term possible effects of the surgery, negative impacts anyway. And also, like, obviously the main thing is pain management. So a lower limb nerve block can last for up to 48 hours, and like a brachial plexus block can last for like 24 hours or so. So the post-op pain is reduced a lot, which can really help, obviously. And also they can do like they can basically put a catheter in to the nerve site and do like an ongoing kind of put lidocaine on like a drip, or bupivacaine or one of the other local anesthetics on a drip into that area, and over a few days, and basically do like a few days worth of just completely blocking any sensory impulses from that area. So, and obviously they lose motor function in that area as well, so it can be, for some patients that you want to get them up walking as quick as you can, it's not the best option, but yeah, so anyway, it's really interesting, and it's all done under ultrasound guidance, and it seems like they just basically stick a needle in and squirt a bunch of local around the nerves, and yeah, so pretty cool. And also they end up needing less anesthesia drugs for the general anesthetic, because there's not experiencing being ripped apart and cut open and whatnot, and also like less use of opiates and other analgesia in the recovery process. So yeah, it was a really interesting talk. And he also talked about intubating patients. So obviously it's a huge challenge here. Some of the goiter patients have a severely compromised airway, or the max fax patients that their whole mouth is, not the right shape, or, invades back into the throat, whatever. So there's obviously, it's pretty much as difficult as it gets here. So one of the things that they do is like a scope intubation. So they'll put a scope down and intubate them that way, and the scope kind of has a like an airway tube on the outside of it, and they'll put the scope down with the tube out, slide the scope out with the tube still in. But a lot of these patients, they have to do like awake intubations, because obviously if you put a patient to sleep and then you can't get an airway on them, you just give them a whole bunch of drugs that affect their breathing and all that stuff, and you suddenly have a patient that's unconscious and can't breathe, and you have no way to get their airway, and obviously bad situation to be in. So he talked about one patient that she had a really big facial mass like this, and basically there's no way to get like an airway down there easily. So he was just talking about how he did like an awake intubation on her, and they'll do like a local nerve block to the all the nerves that innervation of the airway, basically, so that the gag reflex and all that stuff is just removed, and the patient's basically numb, and then they will intubate them while they're awake, and then give them propofol and all that stuff and put them to sleep. So there was another patient that I kind of asked about that she had quite a big goiter. It wasn't huge, like one of the huge ones, but it was quite big, and it was really big, like a long way back into her neck, and also down into the thoracic outlet. So like where your clavicles and your sternum are, if your thyroid is kind of growing uncontrollably, it can sometimes grow down into there, and obviously that's a compressed space. So on your neck it can just kind of grow out, but once it starts going down, it's into a compressed space, and it can compress like your superior vena cava and all the venous drainage into your heart. It can quite severely compress like all of your venous drainage from your head and face into the SVC. But also it can obviously very seriously compress your airway. So this lady had just like at the level of her SC joints, she had her airway compressed like right against her spine, like really, really, really small, like a few millimeters for a stretch of it. And then it wasn't straight down, it was kind of curved off to the side, because her goiter was much bigger on one side than the other. So obviously really, really difficult. You can't just tilt their head back and stick a tube down, like it's winding and whatnot, and you can't put them to sleep before. So awake intubation with a scope. So it's really cool hearing from all the surgeons and stuff here, because they obviously they're dealing with like the most difficult type of cases of that specialty that there can be. It's like that is as complicated as it gets for intubating a patient. Even doing the nerve blocks, like I can't even imagine how I managed to do any kind of nerve block to do an awake intubation when she's got this humongous goiter that's like in the way. Anyway, really interesting talk. They have a medical in-service here like every once or twice a month, I guess. Probably, I don't think it's every week, but like once a fortnight, I think. So, always really interesting. The docs are talking about the most interesting cases, and this is pretty much as wild and wacky as it gets. So, that was cool. And we just played some board games. All the support services kind of had a little board game night, so lab and pharmacy and stuff. We all hung out, played Pandemic, and just here midships. And yeah, that's pretty much it. So tomorrow's going to be busy with screening, and Friday's going to be busy with screening, I think, and then hopefully some interesting cases and stuff. And then Saturday I'm packing up and coming home Saturday night. So I'll be back by Sunday evening and probably just crash, and I don't know if I'm going to go to work on Monday or not. We'll see. But yeah, see you later.